Good afternoon, everyone. I'm Tim Fuchs with the National Council on Independent Living here in Washington, D.C. I want to welcome you all to our newest webinar and teleconference program, Medicaid 101. Today's webinar is being presented by the New Community Opportunities Center, a national training and technical assistance program of ILRU in Houston, Texas. This webinar was organized and facilitated by those of us here at the National Council on Independent Living. Support for the presentation was provided by the U.S. Department of Education, RSA. Without any further ado, I want to introduce our presenter for today, Suzanne Crisp. Suzanne is a real expert on Medicaid. We've had the opportunity, I've had the pleasure of working with Suzanne a number of times now, and she does a really, really great job. Officially, Suzanne is the Director of Program Design and Implementation for the National Resource Center for Participant-Directed Services at Boston College. Suzanne has frequently worked with and trained IL advocates, and she's a big advocate of consumer-directed programs herself. So I know you all will enjoy working with her if this is your first time participating in one of her trainings. And for those of you that have heard Suzanne in the past, I think you know that this is going to be good. So let's get started. I'll turn it over to Suzanne to begin today's presentation. Suzanne?
Great, Tim. Thank you so much. You know, it's a pleasure for me to be here. Conducting these webinars are one of the really fun aspects of my work with NICL and ILRU. So that should automatically make you suspect about the level of my sanity if I enjoy talking about Medicaid ad nauseum. So hopefully this will be inspirational for us all then. So today's discussion is going to be presenting the basic structure of Medicaid. I've also added a few slides about Medicare because increasingly it has become a national trend to look at both Medicare and Medicaid and see how we can improve the case coordination of our dual eligibles. So there'll be about 4 slides on that. We'll also talk about Medicaid eligibility requirements and services, and this will be somewhat dry, but we'll try to make it as interesting as possible. We'll talk about promoting consumer direction or self-direction, and then toward the end we'll highlight a few strategies for appealing decisions made by Medicaid. So on our next slide, I want to talk about how Medicaid came to be. I don't know how old you're all out there, but I was, I guess I was in high school. I was in college in 1965, and I had no idea what all was going on that would really impact health care in America. But Lyndon Johnson created an initiative he called the Great Society. And within that initiative, there was legislation enacted on Medicare to create Medicare, Medicaid, and Social Security. And think about what would happen if the Great Society had not been implemented. We wouldn't have any of those very, very important programs. So that's a very significant year. In the very early years, Medicaid was simply a minimum health insurance for people who were past 65, for dependent children, or for persons with disabilities. It was state-funded, and it was considered a welfare program. And it really, it had very low income and resource thresholds, and it was just a basic health care plan. We know that all has changed now, and we'll look at a few slides to show the growth of Medicare in the past several years. Medicaid is a jointly administered program both by the state and CMS. CMS implements regulations and policy interpretations that provide the framework for the Medicaid program, and then states take that framework and create their own unique designs then. Medicare, on the other hand, is a social insurance for everyone who has paid during their working years. If you look at your pay stub, it will say Medicare taxes and FICA is the Social Security portion of your taxes. Medicaid then is only for individuals with low income and limited resources. Again, we'll talk about what low income means and what those limited resources are. On our next slide, I just want to convey that it's going to be somewhat of a challenge because both Medicare and Medicaid are very, very complex. I don't know anybody that knows everything about Medicaid, nor even one person that knows everything about Medicare, much less people that know both those huge federal programs. With Medicaid, though, it gives us the opportunity to create home and community-based services. And there's going to be a slide a little bit later that talks about how community services were first developed and how important they are to us in our day-to-day lives today. Changes to Medicare and Medicaid require congressional action. In other words, Congress has to say, we want to make a change in the Code of Federal Regulations. We saw many changes come about with the Affordable Care Act. We'll get into detail about those also later. In general, state legislatures decide how much the state will spend for Medicaid. It sets income limitations and resource guides, whereas for Medicare, that is a federal program that looks the same across the nation. States also decide how much to pay Medicaid providers through a rate-setting process, whereas Medicare rates are set by the federal government. And here, I don't think this is any surprise to any of us, and it's certainly not meant to be pejorative, but those with the knowledge about Medicare and Medicaid are typically not change agents. They're typically not advocates. They're typically very detail-oriented people that see things in black and white rather than in shades of gray. So that will be a challenge as we try to make changes, identify changes, and try to make those changes within the Medicaid system. Not only is it tough, but also people are not so inclined to make changes readily. The next couple of slides are going to be about Medicare. So we'll go, So Medicare, then, we know is a health insurance plan that we pay into as we work. The program is quite expansive. Right now, the enrollees number about $44 million. 7 million of those are adults with disabilities. We know that the Medicare budget comprises 13% of the federal budget. And if you watch the news, you know that this is a topic for continuous discussion about sustainability of Medicare and the value of Medicare. Medicare funds are basically acute care funds of acute care services. And acute care services are things like physician visits and hospitalizations and therapy sessions and trips to the ER. So Medicare is divided into 4 different parts. And the reason why I'm going through this is because you may have people that come in for assistance, community assistance, to talk about, the various parts of their Medicare and how that fits in with Medicaid. So it's somewhat important that we understand, what the 4 facets of Medicare are. The first is Part A, and that's for hospital, nursing facilities, home health, and hospice services. And again, this is across the nation. It doesn't vary by state. Part B are doctor visits, outpatient care, and prevention services. And Part C is something fairly new. Part C is an opportunity for people to engage with a private company to combine both A and B and offer them services that are covered under A and B, and oftentimes add additional coverage. So if a person says they are Part C and have Medicare Advantage, then you know that they have a little different plan than just regular Part A and Part B. Part C, another thing that's handy about Part C is that oftentimes because of the economy of scale, private companies can offer lower copays and deductibles then. So you might find that your constituents come in and ask questions about what is the best Medicare Advantage company, and that requires quite a lot of research then. Part D is the prescription drug coverage, and this is also new, and it creates private health cares that solely provide prescription drug services, or we have been seeing Medicare Advantage or Part C picking up prescription drug services too. So I guess the most comprehensive plan would be a Medicare Advantage plan that managed Part A, B, and D. That would be the least confusing to individuals out in our communities. There's also limits on long-term care services and supports with Medicare. Medicare purchases or it reimburses nursing facilities 180 days only, and that's if you're dismissed from a hospital and you need rehabilitative services. They pay up to 180 days, and this basically is the extent of the long-term supports that are offered under Medicare. It's also an entitlement program, so if you're eligible, then you do receive what you need. On the next slide, we talk about Medicare eligibility. To be eligible for Medicare, you have to become 65 and pay contributions to Medicare taxes for at least 10 years. Individuals with disabilities must meet specific disability listings, and you probably are familiar in your state with the state unit of Social Security disability determination. This is the state unit that is fully funded by the federal government, but its operations are state people. And each state has an Office of Disability Determination, and it's here that people make application for disability if they're less than 65 and they need Social Security and Medicare, then they must go through this state unit. To be eligible for Social Security payments, individuals with disabilities have to wait 2 years. And I haven't ever researched the reason for this, but I do think it's a form of discrimination. So what the state is saying is that you are totally disabled, but you can't draw Medicare for 2 years. And that seems peculiar to me, because if a person is disabled, they definitely need health care coverage. So we need to do a little more homework on that to see how we would need to get that changed. Medicare covers basic health services, as we've said, and it also involves pretty substantial cost sharing. So there are premiums and deductibles and copays that have to be met. Then in our last slide on Medicare, it shows that things that are not covered by Medicare. They typically don't cover long-term services and supports, except for those that 180 days in a nursing facility. They don't cover vision, dental, or hearing aids. So now let's look at Medicare. We've gotten an overview of Medicare and how that operates. Now we're going to look at Medicaid and talk about how that can be integrated into a Medicare environment. As you can see, I get mixed up with Medicare and Medicaid, and I can only imagine that people out in the community are mixed up also. The names are so similar that it's easy to get your metas all mixed up. This slide talks about the size of the Medicaid program. It's the largest public health insurance program in the U.S. It covers over 60 million low-income people. In other words, 1 out of every 5 people is eligible and receives Medicaid. It's the largest payer of all long-term services and supports. And here, long-term services and supports are those supports that treat chronic illnesses, usually in the home or in a nursing facility, as opposed to acute care, which is episodic in nature. I go to the doctor, I go to the hospital. There's a start and end to that. Whereas with long-term care, it's a continuous maintenance type program. The Affordable Care Act gave us some substantial changes to Medicaid. As you all probably know, they call it Obamacare now, but the Affordable Care Act was passed in March of 2010. And one of the really significant things about the Affordable Care Act is that from 2014 to 2016, the federal government will finance 100% of the cost of individuals who are newly enrolled in the Medicaid program. Obamacare, or the ACA, wanted to have this expansion because they felt like there were so many people out there who had low incomes, maybe not to the low income threshold of meeting Medicaid, but still people that were just above the threshold who were uninsured. And hopefully states will see the value of this and will implement programs that will encompass this new eligibility enrollment. I know a lot of states are reviewing whether to do this or not. A lot of states are fully on board with it, and they are developing their expansion strategies right now. So it'll be interesting to see how all that works out then. But it is limited to 2 years. On our next slide, we see that Medicaid provides us with the opportunity to provide long-term services and supports. And here we have a little terminology change. It used to be long-term care, but as the disability community has taught us for years, the word care is somewhat maternalistic and has a more of a negative and not an empowering context. So they changed after years and years, the federal government has finally listened, and they now are calling it long-term services and supports. So if you see the term LTSS, then you know that that's long-term care services and supports, and it's commonly used. Initially, Medicaid in the 1965s and later 60s, 70s, and early 80s provided assistance with long-term care only in the form of admissions to an institution, a nursing home facility, or an institution for mental retardation, an ICFMR. In 1970, home health was added, and home health is a service that has a nursing component to it, a skilled care component, and it also has a nurse's aid component, which is more personal care type in nature. In 1981, the Social Security Act was amended to allow services to offer individuals a choice between institutionalization and waiver services. I'll tell you a little bit more about how that came to pass and the significance of that, and give you a little overview of Katie Beckett and the advancements that she presented in the 1980s. So until 1988, 90% of all Medicaid funding was dedicated to either nursing facilities or institutional care facilities for the mentally retarded, ICFMRs. Now, you all probably know that mental retardation is another term that has had a pejorative reflection, and the federal government has been slow to go into the regulations and make this change formally, but they do recognize that intellectual disability is the new term. Many state programs are being renamed. They're taking out mentally retarded in all of their policies, procedures, legislation, and replacing it with intellectual disabilities then. So that's a good thing. On the next slide, talking more about Medicaid. Each state develops and operates their own Medicaid program, and they do so by developing a state plan. And this state plan is a document that is a living document. It can be amended with a lot of trouble, and I'll tell you about that in a sec. But a state plan actually outlines everything that the state is going to do within their Medicaid program. Then it's submitted to CMS, the Centers for Medicare and Medicaid Services, and this is the federal agency that oversees both Medicaid and Medicare. But the state submits the state plan to CMS, and CMS approves it. And then if there are any changes the state wants to make, they have to formally amend their state plan. So if you hear talk about a state saying, well, we'd love to do that, but we have to amend our state plan, know that that's a pretty rigorous process. It usually involves legislative approval at the state level, and then at the federal level, the whole state plan goes under close scrutiny. So if you have something that isn't quite right, but it's in your state plan and CMS has approved it, if you submit an amendment, then that opens up your state plan to all sorts of scrutiny. So sometimes states are really apprehensive about saying, well, let's make that change quickly in the state plan. Medicaid mandates some services and allows other services to be optional. We'll cover that in just a sec. States choose their eligibility groups, the services that will be provided, the payments that will be made for reimbursement, and it also controls provider qualification, who can come into the program and actually provide services and be reimbursed by Medicaid. In 2009, there were 31 million children on Medicaid, 6 million elders, and 9.5 million persons with disabilities. And for the purposes of this course, as well as many other things that come from Medicaid, they don't differentiate between the persons with disabilities and persons with IDDD diagnoses or persons with mental health or behavioral health diagnoses. So what you've got is a great big lump of people that include a wide range of disabilities. Then we can go deeper and look at persons with physical disabilities, and we'll be giving you a resource on how to capture that kind of data, how to retrieve that kind of data from your state then toward the end. So on our next slide, we see that it outlines an expenditure overview, and I'll just highlight a few things here. We know that 15% of individuals with disabilities expend 43% of the funds. Then keep in mind that this 43% does include intellectual disabilities and developmental disabilities, and that group is usually the highest reimbursed population group that we see. Another thing I'd like to draw your attention to is that long-term care, the maintenance of chronic illnesses versus acute care, hospitalizations, ER visits. Of the Medicaid budget, 2/3 goes to acute care and 1/3 is long-term care services and supports. Then, so let's look at the role of the state agency. Each state has a designated state Medicaid agency, and they are responsible for operating, both developing and managing and operating the Medicaid program. They must assure accountability between the state and the federal government. This office does, and it's somewhat limited in what the Medicaid agency can delegate. Certain functions they have to keep. For example, they have to maintain developing quality assurance and improvement plans. They also cannot delegate down rate setting or the development of provider qualifications. This is interesting to note because in a lot of states there is a Department of Human Services. There's a great big, one large agency or office or department. And then under that department there are umbrella agencies. Under this umbrella there are agencies then that operate Medicaid programs. There's a state Medicaid program that has full authority over the Medicaid program, and then oftentimes the Medicaid program delegates to either divisions on aging and adult services or developmentally disabled divisions. They allow those entities to actually manage the program. So you might be hearing if you want to try to make a change and your division says, oh no, Medicaid won't let us do that. What they mean is that their state Medicaid agency, who has total authority over the Medicaid office, would be the office that would manage that change. And the people at Medicaid there are very few change agents there. I know because I used to be one of those people, and the mentality is, don't. Keep a tight rein on the budget is not to be unkind, but that's simply their job. The state also determines their own unique programs. So let's look at the next slide, and that is our question slide. So I think we have a lot of questions, and I've been talking, so I haven't been reading them. So, Tim, if you'll be glad to field those for me, that would be a wonderful thing.
I sure will. Suzanne, Margaret Sebens, I hope I'm saying that right, is going back to your quick overview of Medicare, and she is asking which parts of Medicare have premiums and how much are they?
That's a good question. Each part has premiums. Part A, B, C, and Part A and B and D have premiums. Then if you do have a health plan under C, there are also premiums. Premiums, I was looking on the website last night preparing for this, and basically the deductibles are like in the thousands of dollars. It can range from like $1,000 to $3,000, something like that. It depends on what the service is, what the service category is. Copays are generally a percent of what the cost of the service is, and then let's see, what else do we have? Copays, deductibles, premiums. Premiums are anywhere from $100 to $400 a month. And what a premium is that you actually have to, not only do you have to pay into Medicare when you, as you're working, but once you start drawing it, you still have to pay in to receive it. It's kind of like a health care company, like your own private health care. You have to pay a premium in order to receive it. And if you don't pay that premium, then you won't receive Medicare. In the Medicaid program, they have, here I'm going to get it wrong. It's the SLIMs and the qualified Medicare beneficiaries program, where Medicaid does not cover. Medicaid covers only the premiums for Medicare for a certain class of people. So it's kind of complicated, and I'm not the Medicare expert. So at the end of this session, I'll give you some information about how to go to a website and get more detailed information if I haven't done a good job.
Okay, thanks. Next, Suzanne, Eric Benz writes in with a frustrating situation. He says that recently they've noticed a number of their clients who have been talked into a Part C plan, sometimes feeling bullied into buying it. And after they sign up for the plan, they find out that it messes up their medical coverage with their doctors and prescriptions, et cetera. They've run into this problem at pharmacies, at large pharmacies like Walmart, and they feel like they're being targeted to Medicare recipients. And Eric is wondering if you know if there are regulations regarding selling individuals these plans.
Yes, there are regulations, and there are. That's why it's always so helpful to go to the Medicare website and see what that has to say about it. Keep in mind these private health care companies really want the business. It's almost like a little managed care entity that they've created. Medicare Advantage is kind of like it allows a for-profit private health care agency to kind of manage the Part A and Part B. And so with that, as we know with managed care, there is sometimes a limitation of free choice of providers. Some providers don't accept, the plan. So you're kind of steered outside your normal freedom of choice situation. But without going into too much detail, there are regulations about the integrity and ethical considerations about talking people into Part C. But I just want to encourage us all to go to the Medicare website as opposed to some of these healthcare websites and get the real information. It's my understanding, and keep in mind I don't get out much anymore, but ADRCs, the Aging and Disability Resource Centers, are supposed to be having a Part C and Part D counseling, and a pretty intensive counseling. So I don't know if that's effective out there or not. I know they've been charged with helping people make those decisions.
Okay. Thanks, Suzanne. Let's go back to the phone and see if anybody's in the queue there.
Hi, this is Sheila Kleinrock. I work with MyTay. My frustration is that I have a consumer right now who needs to see an ear, nose, and throat doctor. We're in West Palm Beach. And there was no one that would take her. It was either children or over 65, and she's not quite 65 yet.
Is that it? Sheila, I think I got the message. Medicare providers are there's certain qualifications, and those who meet those qualifications can come forward and become a Medicare enrolled provider and receive Medicaid. Oh, okay.
Yes,
Medicaid environment.
Her to Miami, which is 150 miles round trip to only one doctor.
Okay.
And that's expensive. So she needs to have surgery on her ear. She's had brain tumors before, and the only way to get to this one doctor in Miami is to spend.
Well, as I was saying with Medicare, it works the same with Medicaid, that providers can come forward and enroll. There's a lot of paperwork with both Medicare and Medicaid, and not everybody is willing to go through that paperwork, nor a lot of people feel like the reimbursement rates for both Medicare and Medicaid are so low that they just simply do not want to enroll. And that's really outside the Medicaid or Medicaid's purview. It can do things to try to entice people, providers, physicians and hospitals and clinics to enroll in their program. But if people are not willing to enroll in the program, then there's really not much the federal government can do about that. I believe that the Affordable Care Act does have some incentives for particularly physicians to not only keep enrolled, but also to accept more Medicare and Medicaid patients then. So I don't have a good answer for you.
Thank you.
Okay, thank you.
Okay, and that was the end of our questions on the web too. So, and that was just about 10 minutes. So Suzanne, I'll turn it back over to you and go to slide 14.
Great, Tim. And I'm going to go to my handheld. I was on a speakerphone, so I think I'll do this. I think the sound quality is better and I can hear better.
That sounds good. Thanks.
Okay, yeah. Okay, so let's talk about Medicaid requirements then. As all things that are tied to the federal government, it's very confusing, pretty complex. The Social Security Act created both the Medicare program, Medicaid program, and Social Security. That was part of Johnson's Great Society. So any kind of changes to that are going to require federal legislation. Congress must weigh in. if you ever have the need, and I'll show you how to do that toward the end, if you want to look up the Social Security Act or the Code of Federal Regulations or the State Medicaid Manual, or policies issued by CMS, there are a number of websites that can provide you access. These, I don't know if you're familiar with federal law, but it usually is pretty confusing to read, and it's not very clear. So know that if you look at the Code of Federal Regulations, that will give you clearly what the law is. It's the interpretation of that law, though, that sometimes gives us challenges then. States may not place limits on services or deny coverage to particular illnesses or conditions under Medicaid. So we do know that some illnesses and diagnoses the state must cover, and do so in a way that ensures that the chronic illness is met and sufficient services are provided. On the next slide, more requirements. Services for Medicaid must be medically necessary, and what this means is that a person just can't, as an entitlement, receive personal care or home health services. He or she has to have a medical need. So everything has to be tied back to medical necessity. And sometimes we have trouble understanding that criteria. Sometimes it's set so high that only the sickest of the sick can actually obtain those services because the medical necessity criteria is created too high. And we oftentimes have to advocate for lowering that. Third-party liability rules require that Medicaid be the payer of last resort. So if you have private insurance, or if you're a veteran, or if there's any kind of insurance involved, Medicaid is going to be the payment of last resort, and that includes Medicare also. And generally, Medicaid is statewide. We'll talk about waivers that can be geographically limited in a little while, but mostly services are statewide, particularly state plan services are statewide. And as one of the tenets of Medicaid and Medicare are that people are given freedom of choice of providers. Medicaid and Medicare both identify provider qualifications, and those people come forward and say, I want to apply as a provider of services, and I meet these qualifications. And then they can hold themselves out in the community as a Medicare, Medicaid provider of services, and then people can they can select their provider. Now, in the case of West Palm Beach and Sheila, the selection was limited because of lack of providers. So we need to find ways to entice people to, particularly physicians, to come forward and become Medicare and Medicaid providers then. State reimbursement methodologies must include methods to assure provider payments are consistent with the economy, they are efficient, and they include quality of care principles. While we say they must be efficient, that is one of the reasons why many providers choose not to participate in the Medicaid program, as we talked about just a minute ago, because the reimbursement rate might be lower than private insurance, and certainly the associated paperwork is not a pleasant thing for these providers to manage. Next, let's talk about eligibility. Eligibility is categorically related. In other words, it's tied to a certain population, and these populations are elders to be 65 years or older, to be visually impaired, or to be under 65 with a disability. And we said that the state determines the level of disability, the admittance, so they are the gatekeepers for disability determinations. We know that in 33 states, if you receive supplemental security income, which is SSI, that you automatically receive a Medicaid card or Medicaid services. And in 11 states, one has to enroll independently in the Medicaid program. It's also means tested, and what that means is there are certain resource and income considerations then, and we'll talk more about those in just a minute. On our next slide, we'll talk about financial eligibility. Financial eligibility is set by the state. States have the option to raise it to 100% of the federal poverty level, and in state plan services as well as waiver services, we typically always see the federal poverty level as the gauge or the SSI level of payment as a gauge for admittance to eligibility. Some states have 75% of federal poverty level. Others have 100%, and we'll see in later slides. We'll see that waivers also allow you to increase some eligibility by as much as 300% of SSI or 150% of poverty. It also allows employment options such as supported employment or ticket to work. The medically needy category allows also, when people, let me back up. When people don't meet the financial eligibility to be Medicaid eligible, then there's what we call spin down or medically needy, and this is where a person has fairly limited income, but it's not sufficient to meet Medicaid roles, but they have some pretty enormous hospital expenses. And what they can do is come into the Medicaid office and apply for temporary Medicaid in the spin-down category, and they're in the amount that they are over income, they can deduct expenses, medical expenses, from their income and then achieve temporary Medicaid eligibility not to exceed 3 months then. So that's always a good option for those with catastrophic health events in their lives, though. Next, we're going to talk about the mandatory services. I won't read all of these, but you will have those for resources for later and can read those now yourselves. I want to draw your attention to nursing homes that mandatory services since the beginning in 1965, nursing homes have been a mandatory service. So when we talk about the biasness of nursing homes, it's because nursing homes back in 1965 were created as a mandatory service that states had to provide then. So it's taken us all these years then to create an optional service category for home and community-based services. In the optional services, on the next slide, we see that personal care, the assistance of daily grooming tasks, bathing, dressing, and assistance with homemaking and shopping and errands was added in 1980. Prior to that time, services were just simply not available, except under the home health rule of Medicare, which is quite limited. Also notice that assistive devices and home medical equipment and DME, durable medical equipment, are also optional case management. Are optional services, as is case management. Then, so states can or they don't have to provide these services. There are about 14 states that don't offer personal care in their state plan. They do offer some limited personal care type services in waivers, but no state plan service then. So now we're at a point where we can stop and ask questions. So I'll turn it over to Tim again.
Okay. Thanks, Suzanne. First question is from Seal Stevenson, and Seal asks, Suzanne, who covers the service cost, the copay cost and prescription costs with those with dual coverage with Medicare and Medicaid? Is it Medicaid or Medicare that picks up the costs? And also, can you explain how someone becomes eligible for, how someone becomes dually eligible?
Sure, that's a good question. Medicaid covers the cost of Medicare Part A and Part B for those who are dually eligible. So Medicaid picks that up. And how they become eligible is simply when they sign up for Medicaid, then they ask the question, are you also eligible for Medicare? And then that goes into the system, so they become earmarked as dual eligible. And we've seen a lot of activity about dual eligibles, and I'll talk later about that too, but just briefly, there has been a real national interest in coordinating Medicare and Medicaid services, even to the point of integrating under one global budget, both the Medicare and Medicaid services then. And to that end, recently CMS offered states the option to come on board as a demonstration state for dual eligibles and to come up with strategies that integrate those two services. So that's going to be rather exciting. So when we talk about dual eligibles, know that that's one of the hot topics across the nation, and we'll be seeing more from that. It's all based on the premise that you have your Medicare silo here and your Medicaid silo here, and the two don't talk. There's no case coordination between the two. And so that's going to be an exciting proposition, and hopefully in a couple of years we'll have a webinar on the success of the dual eligibles.
Okay, thanks. Wow, these questions are really rolling in. Let me take one more from the web, and then we'll go to the phone. And folks, I'll do my best to get to all these. If we don't have time during this break, we'll certainly cover them before we end the call. Okay, again from Margaret Stevens, concerning eligibility. What levels or types of visual impairment will qualify, and do those qualifications apply at any age?
They do qualify at any age, and here I have to put my my hat on. I used to work at the Disability Determination Unit in the state of Arkansas, and as I recall back then, this is ancient history, but it was a vision of 2200. And that was not correctable. And here I'm going to do a poor job of this. That's basically it. I bet we can find out some more information on that. And let me make a note to myself. I will send out in a note tomorrow that's coming to you all. I'll send out information on Social Security disability, and there's a handy little thing that you can have. It's actually the listings that they use to determine eligibility. So I think that's what's being asked here. So that will give you an idea. If someone comes into you and says, well, they turned me down at Social Security, what you can say is, well, what was your diagnosis? Well, let's look here and see what you would need in order to qualify. So I'll send that out to you guys tomorrow. That'll be a nifty thing.
Okay. Thanks, Suzanne.
I'm wondering, does every state follow that spend-down rule that they all adhere to, allowing a spend-down for a consumer if they need Medicaid?
No, that's optional, I'm afraid. The state has the option to either recognize a category medically necessary or not. And that's a shame.
Yeah, thank you.
Pat Rimkus asks, what are the chances of changing the equation utilized for spend-down amounts? Many of our consumers are placed at poverty level due to high spend-downs. Do you have any advice?
Oh, I bet. These the spend-down is managed on the federal level, so it would take a, you know what, here I'm going to say that I need to get back with you on this. I know it's an optional program, but I'm not sure if the federal government sets the spend-down limitations or the state does. But I can look that up very, very easily, and I may be able to look it up while we're still on the phone. But for sure, I will answer that question in tomorrow. But I want to give you the right answer, not a guesstimate.
Okay, thanks. Here's a quick question. Pam Davies is wondering about prosthetics. are they covered under either program? For example, prosthetic eyes.
For Medicaid, that would be under home medical supplies and DME. And again, that's an optional program. So what you'd have to do is look at your state program to see if they did cover that. But the categories by which you would cover that would probably be home medical or DME category. And at the end of this call, I'm going to be giving you a website, and you can tap on your state and see its Medicaid program. And it actually is a pretty simple way to, kind of look at all the things that is covered with your state or not. So it's going to be a nifty little tool also.
Okay. Good. Well, we're a little short on time here. Let's see if we can fit in a couple more. Do any of the Medicare plans cover mental health services, inpatient or outpatient services?
I know that they do, and behavioral health and services, even substance abuse and mental illness, has become such a hot topic these days that if they don't cover it now, I bet they soon will. Specifically about what is covered under Medicaid, I have to say that I'm going to research that, and I will get back with that person to outline what is covered. With Medicaid, it certainly is covered. It can be a waiver service, and certainly there's a new authority that can be modified to cover behavioral health services strictly for individuals that want to live in the community, but you'd have to qualify also for Medicaid.
Okay. All right. Thanks. So, Suzanne, I'm going to go ahead and flip to slide 21.
Okay, thank you. On slide 21, we will see that talking about home and community-based services. So here's where we finally get down to the things that probably matter most to us. This slide is just a highlight of the various authorities that have been created for home and community-based services. We know that prior to 1981 that only home health was provided in the home. Other than that, if a person had a chronic need, it was either dealt with in an emergency room, a hospital, or a nursing facility, or an ICFMR. But in 1981, Katie Beckett and her family took Medicaid to task. Katie Beckett had significant developmental disabilities, and her mother sought help for her. And the state said, well, if you put her in an institution, we'll pay for everything. But if you keep her at home, we'll pay for nothing. And Katie Beckett's family, particularly her mother, took exception with this and even appealed to President Reagan at the time. And President Reagan then said to CMS, you need, back then it was called the Healthcare Financing Administration, or HCFA. HCFA, you will change the law. I want the law changed to where people can have an option to either be served in the community or in their home. So they made it an option for states to follow. And just imagine where we would be if Katie Beckett and her family had not taken on such a strong advocacy role with the Medicaid program. And certainly it was helpful that she had the ear of the president. Later on, Social Security was added to allow Section 1915A, which is a voluntary managed care authority. We don't have many of those. I think there are one or two in the nation. But we do have a lot of Section 1915Bs, and this allows for mandatory or voluntary managed care. We also have, and as we talked about, the Section 1915C allows those who would qualify for an institutional level of care to receive services at home. Let's continue on with some of the federal authorities. And these two slides, both 21 and 22, can kind of be your guide for, these are all the various authorities. We're going to talk about each one of those quickly here. but know that all these different authorities. So if a person says a waiver, you need to know what kind of waiver it is, whether it's what alphabet the waiver is. So on slide 22, we see that we also have state plan of services, and these are basic services, both the mandatory and option services that are not waiver services that anyone can receive if they have the medical need for and they are eligible for Medicaid. We talked a second ago about the C waivers. Something new is the 1915I waivers. I just want to go through these quickly now. We'll hover on a few of these in just a moment. The 1915J waiver is a self-directed option or a cash and counseling-like program. The Community First option, which is getting a lot of attention, is a 1915K, was created with the Affordable Care Act. And then the managed care authorities are A, B, that we've talked about, and then Section 1115. You might hear state people throw around, we're going to apply for an 1115, and what does that actually mean? So this is kind of like your sheet for this. These are what all of these are, and we'll explain those that come closest to what you all do here in just a moment. For state plan services, these are available, as I said, to individuals who are on Medicaid and have the medical need for a service. Home and community-based services are usually considered personal care type services, home health services, rehabilitative services, targeted case management, and self-directed personal care. Again, if any of these services in your state, these are all optional services. So keep in mind, most optional services that meet the definition of home and community-based are optional services. So that's kind of an important political note for us to make. On the next slide, we see how to receive a state plan service. The individual must be eligible for medical services under the state plan. They have to have there must be needs-based criteria established. What that means is that the state sets the level of medical need by which to be eligible to receive that service. The individual must reside in the community and income that does not exceed 150% of the federal poverty level. The Affordable Care Act also allowed us to expand eligibility up to 300% of SSI eligibility for some of our new waivers. That's always been an option for the 1915Cs. And here we might go back and talk about that. Well, no, I think I'm going to talk about it here. Yeah, I'm going to talk about it next then. And these are not in alphabetical order necessarily. I wanted to pick out the ones that would be most relevant to you all. So the 1915C allows coverage of services in a home-like setting. It also home-like setting is right now broadly defined as the home or an apartment or an assisted living facility, a group home, residential settings. Know that CMS is looking at modifying and tightening that setting requirement. So we will be seeing something come from CMS in the next whatever. They've been saying in the next few weeks since last year, so I don't know. States can set different geographic limitations. For example, if they want to pilot a program in some geographic area, then they can do that. Or if they have a strong provider group here and they don't have those kind of providers anywhere else in the state, they can just serve that one particular area while they develop a provider network. They can offer services to a particular group. For example, persons with disabilities would have a different service package than developmentally disabled or persons with traumatic brain injuries. And then here is where it talks about the use of the higher income ceiling. Because nursing homes allow a higher ceiling for income eligibility, the 1915C amendment said that we want to take on the same nursing home financial eligibility as a nursing home has. So that's an important. And this is 300% of SSI. SSI currently is at $710. So annually, that would mean that if a person had income of less than $25,560, that they might meet the financial level for home and community-based services. So that's substantially higher than the regular Medicaid program at 100 or 150% of poverty. The next slide shows that the use of 1915Cs was intended to meet the rising cost of long-term care services and supports. We have more people entering the long-term care system, and with all of us baby boomers, and we're also living longer, so that is putting an additional strain on the long-term services and support system. Waivers can also serve a diverse target group. For example, there are waivers for people with autism or AIDS or strictly substance abuse. So some refer to these as little boutique waivers, but there are smaller waivers that can be directed to a small population group. 1915Cs allow for consumer-directed options, both the employer authority and budget authority. Currently, there are about over 300 waivers, serving 1 million people at a cost of about $28,000. The primary vehicle to offer non-institutional services to individuals with significant disabilities are 1915C waivers. In your state, probably that is the most common waiver of serving people in their homes then. On the next slide, I want to draw your attention to another waiver program. It's called the 1915I, and it amends the state plan through the Balanced Budget Act. It was established in 2007, and it allows, this is important in that it allows the states to offer home and community-based services without the link to nursing home care. For 1915C waivers, people have to meet the level of care that one would meet if they wanted to be admitted to a nursing home, and that's pretty substantial. It requires, substantial assistance with ADLs and IADLs and some skilled care. But with the emergence of the 1915I, states are now able to create home and community-based services for people who maybe just need personal care or a few home health services. We've been seeing some activity here. About only 7 states have applied for 1915I programs, and basically it's been to cover behavioral health or self-direction. The 1915J might be familiar to some of you. This is the codification of the cash and counseling program. In other words, if you elect to have a 1915J program, it will be a PASS program, a personal assistance services program that offers budget authority, the use of a budget, and purchasing permissible goods and services, and also the ability to hire your own staff to come into your home and provide personal care type services. States may limit or target this program. I think there are only about 6 states that operate a 1915J, with the largest being Arkansas. The 1915K is a community first choice option, or some call it a CFCO, but it is a 1915K. It was added with the Affordable Care Act in 2011, and it allows states to provide a person-centered type community-based care, attendant care service. And the federal government really wanted states to take advantage of this, so they offered them a 6% enhancement to the life of the Medicaid program. And what that means is, and I didn't have time to cover it initially, and may not have time here, but the federal government supports state Medicaid programs by matching certain the matching services. So, in other words, states pay for half of their Medicaid programs, and the federal government pays for half of their Medicaid programs. So when you talk to your state, just realize that there is at least one half of each dollar paid for by the federal government. Now, in states that are less resources, states like Mississippi, Arkansas, Tennessee, the federal government pays even greater amounts, as high as 80% of the Medicaid program. I think in Arkansas, last I looked, it was about 75%. So keep in mind when state folks say, well, we don't have money for this, keep in mind they only have to come up with like 1/3 of the dollars. And with Community First option, then they get an additional 6% on top of that. The only problem with Community First option that it is targeted to individuals who meet level of care. So they have to be a person with pretty severe chronic illnesses then. More on Community First option, our next slide. Basically, it's attendance services with helping people accomplish a daily living task, and it can be hands-on, supervisory in nature, or queuing in nature. And that's important. Some states craft their programs with hands-on assistance only, so if a person has to be reminded or supervised while they actually perform the task, then they're not eligible for that service. But the Community First option recognizes supervision and queuing. It must be consumer controlled, and what that means is that to the degree permitted and desired by the participant, that he or she has flexibility and control over the services and those that provide those services. One thing that's very interesting is that this authority requires the establishment of a development and implementation council that includes a majority of members with disabilities, elders, or their representatives. And I think this is where some CILs can come in handy with helping the state meet this requirement by bringing names in of people, advocates, and persons with disabilities to serve on those boards then. The next couple of slides the next slide talks about managed care. Managed care apparently is one of the new sexy things out there. Right now, 16 states operate with managed care programs, Medicaid managed care programs, and by the end of 2014, another 14 states will have come on board with managed care. Basically, managed care is a system where either for-profit home health plan or a not-for-profit health home plan. It contracts with the state to provide particular services, waiver type services, and the state pays that entity a capitated rate. In other words, a rate, it's a per member per month rate. So whether you use the service or not, that managed care entity does receive that rate. If you're a high user, then the managed care entity probably loses money on you. If you're not a high use person, then the managed care entity probably gains a little profit there. The authorities by which you can manage care include the 1915I, the 1915B, and an 1115 demonstration. Let's see what else I need to say about that. Typically, the C, the I, and the K are fee for service, and what that means is that you go to the doctor, you receive a flat fee. You have personal care of an hour, and you receive a flat fee. So we've got the two different funding sources or funding types, fee for service and in the capitated managed care rate. 1115 demonstration projects. Some states are redesigning their programs, their Medicaid programs, to where they're not so complex as to have a waiver here and there and an authority here and there. They're looking at their program and saying we just want one program. We want to have one set of quality assurance and improvement mechanisms. We want to have one eligibility. We want to have one quality or not quality provider enrollment process. States like Vermont and California and I believe let's see, I believe that Florida is attempting to develop an 1115. Minnesota is developing 1115. So instead of all of the things that we've talked about, it's just going to be one program under a demonstration project. And what the state does here is that it creates this big structure for managing their Medicaid program, and it goes to the federal government and says, we want to waive certain things, like we don't like this about the C, so we want to waive that, and we don't want like this about the I, and we want to waive that. So it's kind of like a create your own program, and we're seeing more and more states consider that. In the past, before recent years, the 1115 was used for things like the cash and counseling demonstration or prescription drug demonstrations then. So we're nearing the end. Appeal rights. Let's talk about dispute resolutions. All states must offer a fair hearing. And if you qualify for a fair hearing, if you're not given the choice of home and community-based services, if you're denied services of their choice, and if you're denied freedom of choice of providers, and you're denied, you're eligible for a fair hearing if you are denied services, suspended services, or your services are reduced or terminated. And each of your states are going to have a fair hearing process then, and I'll talk about how to find that in just a second. Some states offer, we know they have to offer fair hearing systems and processes, but they also offer grievance and complaint opportunities that are less formal than a fair hearing. You can just say, well, I didn't like this, and I want to tell somebody what I didn't like, and I want them to talk to me about how we can correct those things. So some states have those and some states don't. In order to find out more about your Medicaid program, we are going to give some resources via an email tomorrow, and it'll also include the answers to some of the questions that I couldn't answer. But in the meantime, I want you to know that if you access this website, and it's www.medicaid.gov, if you access that, it will bring you into the CMS website, and as we know, the CMS website contains Medicare information and Medicaid information. So you would want to tap on Medicaid, and then that will take you to a link that has a map, and you can tap on your state, and it will tell you, it will give you examples of the waivers in your states. And it will also then lead you to where you can find additional information actually on the state website. So it's a new and improved website. In the past, say a year ago, the Medicaid.gov website was pretty messy. It was very confusing, but this redesigned website is awfully nice. So I'd invite you to look at that. So again, it's Medicaid.gov, and then tap on Medicaid, and you'll get into the system, and you'll probably be amazed at what all you find there. And I see that Tim has just put this on the website or the webinar. Thank you. So I think that leads us to questions. Sorry, I was got rushed there.
No problem.
Okay, so this is our final Q&A break. Ron Kutcher is wondering if you could elaborate more on nursing home payments that come from the state.
Okay, nursing home payments that come from the state. Well, we know that nursing home is a required service under the Medicaid state plan, and we also know then that depending on your medical assistance rate, that the federal government pays a portion of the fee. So let's say you're California and you are a rich state, and your what would they call FMAP, or medical assistance participation rate, is 50%. So the rate that the nursing home would be paid part by the state and part by the federal government. If you were in Mississippi, then a substantial amount would be, quite a bit substantially more, would be paid for by the federal government. As far as rate setting, that is probably a topic for another day, and I would not be the person to do that. Rate setting for nursing homes is a state function. It's not tied to Medicaid rules or regulations. Medicaid simply says that it has to be adequate and efficient, and the state negotiates then the rate of pay with the nursing home lobbyists, with legislatures, and with a number of other things. So it gets to be a long and involved question. You might find some information specifically about your state if you follow the websites that I just gave you.
Okay, thanks, Suzanne. Well, here is the $1 million question from Melinda Mays. Maybe you have some insight for us. Why is it that home and community-based services are still considered optional when they're cheaper than nursing services? Why is it so hard for us as advocates to change that?
Well, then that's a great question, and it is the $64,000 question. We know from the beginning of the slide presentation that back in 1965 they created this thing called Medicaid. And at the time, I'm sure that certain lobbyists and people were giving the federal government pressure on what to include or not to include, and nursing home lobbyists were probably there. But it got into the law that it said that nursing home services are required under the state plan. So we know in 81, then we had the Katie Beckett waiver, and the 1915C waivers came to pass. But waivers are still considered optional. And what it would take would be a change in the constitutional law, the Social Security Act, to make home and community-based services mandatory. So that's what it would take. And apparently that's just harder than the dickens to do, because we sure haven't made much headway on it.
Thanks. Well, we'll keep working on it.
Yeah.
Let's
I will say, Tim, just that in early on, the number, it used to be like in the 1990s that nursing homes were paid 80%, and home and community-based services were, much less than that. And now, in many states, it's looking more like a 50-50 proposition then. In other words, what I'm saying is that 50% of Medicaid funds go to nursing homes, and 50% of Medicaid funds go to home and community-based services. So we are making a dent.
Good. Okay, thanks. Let's go to the phone and see if there's anybody in the queue there.
There are two questions waiting. The first is from Paraquad Ake of Paraquad. Go ahead.
Hello, my name is Daniel from Paraquad in St. Louis.
Hi, how are you?
Hi, I'm well, Susan. Thank you for answering my question. My question was concerning intermittent catheters.
Mm-hmm.
I myself and several of my participants use closed system intermittent catheters.
Mm-hmm.
And as you're surely aware, they are no longer being funded by Medicare and Medicaid.
Mm-hmm.
I wondered if you could help provide some insight onto that and onto why it's now necessary to have to be on straight caths and to have 2 UTIs, documented urinary tract infections, before they'll realize that it is a necessity. I wondered if you had any insight.
I don't. But I'll be happy to research this for you, Daniel, and hopefully I can get to that research tonight and get you an answer. I mean, just superficially, it doesn't sound like it makes much sense, but then we are dealing with the federal government and state government, so let me do some research on that.
Thank you.
Okay, we have one more question on the phone. Is that right?
Yes, our next question is from Denise Howard of Life Incorporated. There are 3 additional on her line.
Hello.
Hi there.
Okay. You want me to ask a question?
Go ahead.
Yes.
Yep.
Okay, my name's Bob, and I'm from Life Incorporated, too. Mike, I heard you say that you needed to amend the Social Security Act. I've never known that that's where you would go to try to advocate to make those services mandatory. Have you got any suggestion, the best approach to start that or attack that?
No, I don't.
Let me just add a little bit more to that.
Sure.
The reason I'm saying that is because each state's Medicaid is different. So, the only way to get it made mandatory across the board is through the Social Security Act, correct?
That is correct.
Yeah, that's kind of why I'm asking.
Okay. Amending the Social Security Act is the only way that I would know of, because the Social Security Act, it does create Medicaid, and it specifies out, what is mandatory and what is optional. So that's the part you'd have to change. How to get that done? If we haven't done it by now, we may not be able to do it. I don't. In other words, I don't know what the impediments are, other than the nursing home lobbyist and whatnot. I think when we had the Olmstead decision, that was a huge push for home and community-based services, and keep in mind that is a law that says you have to make them available. So in essence, it's almost in the law. It's just not. It's just not well protected. In other words, if a state had budgetary issues and they said, well, we're going to get rid of all of our optional services, they could get rid of home and community-based services, but then they'd still have Olmstead, and that's a law. So I'm wondering if we know that more and more funding is being channeled to home and community-based services. We know that less money is being channeled to nursing homes, and we know that HCBS, home and community-based services, are protected by Olmstead. So I'm not sure that we even necessarily need to change the law. I think it would be a good thing to do, but I don't know that it would be. It's that critical, just because of the Olmstead law.
Well, the law being there and the option being there, they limit the option to where it's so hard to get on a waiver or pick up something that just because the option's there doesn't mean anybody can take advantage of that option.
Yeah, I don't know.
It takes years.
Yeah. That might be a good webinar for Tim to have sometime, or a good open discussion of what are the pros and cons of doing this, and how do we do it? How do we actually do it? I mean, the simple thing is contact your congressman. If you want to get a law changed, you have to contact your congressman.
Yep.
But I would think that there's been a strong advocacy forces doing that. So I'm sorry, the best answer that I got.
That's okay. Thank you for taking the question.
Okay, thanks, Suzanne. And Bob, we are, let's see, we're just about out of time. I'm going to try to fit these last couple questions in. Let's see. One of these was also about dual eligibles. You already answered that. So let me move on to this one. Just quickly, I know you wanted to follow up by email about spend downs. But Margaret Stevens asked if you could just elaborate a bit on the spend-down programs for those who are over income to help her understand. Can you say just a few more words about that?
Sure, and I will do a better job tomorrow, I'm sure, in writing. A spend-down is if a person has large medical bills and their income is over the level for eligibility with Medicaid, they can still come into the Medicaid office or the county office and file an application for Medicaid spend down, saying that they have and what the caseworker will do is they will calculate their income and how much the income is over the amount of eligibility, and then start reducing that over amount by their medical bills. And then once that person gets into the threshold of eligibility, it's on that date that they are Medicaid eligible for a period not to exceed 3 months then. So they're temporarily, so every bill then that falls on that date and beyond then is payable by Medicaid. It's not a perfect application process at all. I used to do those when I was a caseworker in Arkansas. And we don't know for sure if your state actually does have spend down. I don't think, Margaret, but that would be the process that they would use. They would be spending down all of the income that they are over to qualify for Medicaid.
Okay, great. Thanks, Suzanne.
Yeah.
One quick thing before I check the phone one last time. In regards to your eligibility slide, someone asked if you could just quickly define medical need.
Yes. Medical need would be the criteria by which the state approves you. We know that visually impaired is a qualifying event. Also, to be eligible for Social Security disability, one would have to meet the level of Social Security disability regardless if they drew Social Security or not. So if you were a disabled person and you weren't eligible to draw SSI, you would still need to go through the eligibility determination process for the medical determination. In other words, in order to draw, if you're an adult and you're not a mother of a child on TANF or something, then you would have to qualify with your disability, and the Medicaid agency uses the same criteria as the Social Security Disability Determination Unit does to establish your medical eligibility. So we have eligibility into the program, and then we have medically necessary. Once you're on the program, you have to be medically need personal care. Like if I were on Medicaid and I were healthy, but I just thought I'd like to have some personal care or something, you just can't get that. You have to be medically eligible for receiving personal care, and it's usually like criteria like must have assistance in 2 ADLs and 1 IADL to meet the medical necessity of personal care.
Okay, great. Thanks for the explanation. Suzanne has been generous enough to provide her contact information here on slide 36. And there's our project information on slide 37. So with that, I'll close today's call. Thank you so much for being with us, everyone. Don't forget this will be archived on ILRU's website. So if you want to review it or share it with any of your colleagues, you'll be able to do that within about 48 hours. Suzanne, thanks so much for a wonderful presentation. We really appreciate it.